nervous system. All right, now let's move over to slide 9 and discuss how cerebral palsy is diagnosed. This occurs clinically by delays in motor development and through abnormalities on a neurological exam. The diagnosis, unfortunately, cannot happen at birth since signs of CP are not present at that time. In the more serious forms, the signs will appear within the first year and during the second year for the less severe cases. So within the first to second year of life, doctors will be able to diagnose a child with some form of cerebral palsy. One of the biggest keys to diagnosis is the development of primitive reflexes. The sucking reflex and the hand grasp reflex are two examples of these primitive reflexes. During normal maturation, these reflexes become more voluntary movements for the child. In our textbook, figure 24.5 on page 428 represents a timeline that goes through the normal maturation and how a child will go from these primitive reflexes to more voluntary reflexes. I unfortunately couldn't find a good picture of that online that was better than what was in the textbook, so you can refer to that again on page 428 for figure 24.5. Okay, moving on. In infants with cerebral palsy, these reflexes last longer than just infancy. So it takes a little bit longer for them to get through these or move through these reflexes. Other examples of these primitive reflexes are what's called asymmetric tonic neck reflex. And illustrated here, a good picture of that on figure 24.6 in our book. And tonic labyrinthine reflex, again, which is also illustrated in our book in figure 24.7. Again, I couldn't find really good pictures of that to put on my PowerPoint, so I apologize for that. So you just need to refer to our textbook for those. And both of these, the asymmetric tonic neck reflex and the tonic labyrinthine reflex, are both key in helpful diagnosis for cerebral palsy. If the infant is unable to do these two reflexes, that could be a pretty good sign that there may be some form of cerebral palsy. As these primitive reflexes disappear, postural reflexes start to emerge in the child. Again, figure 24.5 illustrates this timeline and how these different reflexes all move about and how the child would go through. Postural reflexes include what's called head righting, a parachute reflex, and the protective extension reflex, where the child would fall down and put the arms out and protect himself from injury. These serve as a precursor to the infant rolling over, sitting, and eventually walking. Okay, next, as I discuss the subtypes of cerebral palsy, please refer to slides 10 and 11 with this. Slide 10 will go through the information part, the names of the different subtypes, and slide 11 here I was able to find a really good representation, illustration of the different forms and subtypes of cerebral palsy. So I'll go through that. Probably want to look at slide 11 as I'm going through and describing the different subtypes for you. It'll match up pretty close with that. With these subtypes, they're divided into different groups by their physical appearance according to neurological findings in tests and the body limbs that are affected. And there are three groups of subtypes. One is spastic, next is dyskinetic, and then lastly is ataxic. Spastic CP is the most common group and is characterized by an increase in muscle tone as a result in increased resistance to muscle stretching. So there's limited movement here. In spastic hemiplegia, one side of the body is affected, and it's usually the arm being more affected than the legs. Next, in spastic diplegia, the legs are mostly affected. And in spastic quadriplegia, as the name might lead you to believe, all four limbs are affected, as well as the trunk and muscles that control the mouth, tongue, and pharynx. So a lot of the body, unfortunately, is affected with that type. In dyskinetic CP, here we're characterized by abnormal movements, and these movements can range from jerky movements to slow writhing moves and also to some type of twisting movements for body and the limbs. The first subtype here, chorea, this is the least common type, and this type has some rapid, random, jerky type movements to identify that one. Athetoid is described as having slow, writhing moves that will flow together. Dystonia has repetitive twisting movements and also distorted posture. And the abnormalities in muscle tone with dyskinetic CP affect the entire body, and these abnormalities can change from hour to hour for the person and also from day to day. So really it's going to depend on what type of day the person's having as far as how they're being affected. Okay, the third subtype here is ataxic CP. And here there's going to be an abnormality in the cerebellum of the brain. This type is characterized by jerky and uncoordinated movements without smooth transitions in between these movements. If the person affected with ataxic cerebral palsy can walk, they're usually going to have a wide-based, unsteady gait and probably need some type of walker to help them move or crutches, which we'll talk about in adaptive equipment as we go through further on here. It's going to be very hard for them to control their hands and arms, which makes reaching for things and movement timing to grab some things quite difficult. And also, it's not on the chart here, the illustration of the different types, but there is a fourth type here, which is classified as called mixed cerebral palsy. Here, there's more than one type of cerebral palsy is present in the individual, but one pattern of movement doesn't dominate over another. So it doesn't really have a specific name. It's just a mixture of maybe two different types put together. Okay, let's move now to the associated impairments of cerebral palsy. And here I've got a big list of these. The intellectual disabilities are hard to assess since most intelligence tests require some form of motor and verbal responses. So depending on the type of cerebral palsy that the individual has, this could be pretty difficult to come up with this test. The visual impairments are very common and are also very diverse. Here we can have a range from very severe disability, almost blindness, to just basic farsightedness. The hearing, speech, and language impairments are also common and affect about 30% of all cases of cerebral palsy. Hearing loss is associated with an intrauterine infection and the intrauterine infection which ultimately causes cerebral palsy. Thalamus or ganglia injury that led to CP is associated with many speech issues, so language difficulties here. And a child with cerebral palsy with normal cognitive development may still show some signs of expressive or receptive language disorders. Next, seizures. And seizures affect about 40% of cases and are associated with a more severe intellectual and physical disability. Feeding and growth impairments are caused by some form of underlying eating or digestion issue. And here, depending on the severity, the individual may need a feeding tube to help them get proper nutrition. And their poor nutrition and the lack of weight-bearing activities often leads to some bone density issues, so further issues that this individual needs to have taken care of. And then lastly, the behavioral and emotional disorders represent a quality of life issue, and really how their needs are going to be met is critical and another part of